Hi, I'm Rob Bossert, Principal Investigator for the Appalachian Mind Health Initiative, a new study being coordinated through West Virginia University and funded by the Patient-Centered Outcomes Research Institute. I'm here today to provide you with a brief overview of the study, the requirements for patients, clinicians, and participating sites, and provide some additional information about the process for becoming involved. As I mentioned, this study is funded by the Patient-Centered Outcomes Research Institute. PCORI was established to fund research that can help patients and those who care for them make better informed decisions about the healthcare choices they face every day, guided by those who will use that information. More information about PCORI, its mission, and its funded projects is available at their website that is provided here, pcori.org. The principal investigators for the study include myself. I'm Dr. Rob Bossert. I'm with West Virginia University. I'm director of the West Virginia University Injury Control Research Center, an associate professor in the Department of Behavioral Medicine and Psychiatry. My co-principal investigator for the study is Dr. Ronald Kessler. Dr. Kessler is a McNeil Family Professor of Healthcare Policy at the Harvard Medical School. He and I comprise the principal investigators for this team, and we're joined by a number of co-investigators throughout the U.S. and some international partners. As I mentioned, this project is being coordinated locally through West Virginia University. Our central team here includes Mary Holloran, who is the project manager for the PCORI effort, Michelle Tonkin, who is our research liaison. Those who are collaborating with us will get to know Michelle very well. She is the primary point of contact for the study team with participating clinicians and sites. And Dr. Kara Stokes, a postdoctoral fellow, working directly on this project. This project is referred to as the Appalachian Mind Health Initiative, or AMHI for short. AMHI is a pragmatic clinical trial of internet-based psychotherapy for patients in rural communities who are being treated for major depressive disorder. AMHI will have a website that's being developed at this time. The link is www.amhi-home.org. We'll provide that information at a later time in all recruitment and education material that's developed. The information that's provided here will also be provided on the website with other useful information for study participants. We believe that this study is a critical opportunity for improving care of patients with mental health disorders, particularly major depression. I'm sure everyone is aware that there is a high need for health services, including psychotherapy, for residents in rural areas. Patients in rural areas who desire psychotherapy typically go on a waiting list or travel long distances for treatment due to a shortage of mental health providers and geographic dispersion, both of the patients and the providers. I'm sure we're all aware that there's a shortage of mental health providers, particularly trained psychotherapists, in the nation that's impacted rural areas most heavily. And some statistics to back that up are here. Approximately 65% of non-metropolitan counties in the U.S. lack a psychiatrist, 47% lack a psychologist, and 81% lack a psychiatric nurse practitioner. It is our hope that AMHI will fill these gaps in care by providing evidence of the alternative treatment strategy and some additional evidence about who that treatment strategy might work best for. The primary goal of AMHI is to demonstrate to study the efficacy of internet-based psychotherapy for patients living in rural areas. A secondary goal is to help provide clinicians with information about who that treatment would be appropriate for. We know that MDD, or major depression remission, increases substantially when patients receive their preferred type of treatment. We hope to address this mismatch between treatment availability and treatment preference by offering remote internet-based cognitive behavioral therapy for those who would prefer it. We hope that this goal, one of the goals of the study, is to provide information that will be actionable for future patients and providers on when and for whom ECBT would be most beneficial. In order to do this, we need to recruit 3,360 patients over a 24-month period. Participants in this study will begin recruitment for participants in the study in March of 2020. Active recruitment will continue for 24 months, and all patients participating in the study will participate for 12 calendar months. So we will be engaging with patients for the next 3 calendar years plus, or next 3 calendar years beginning in March of 2020. The eligibility criteria for patients who are offered an opportunity to be included in the study are a diagnosis of major depression without a previous diagnosis in the past 6 months or treatment for major depression in the past 6 months. They cannot require inpatient psychiatric treatment at the time of diagnosis. They can have no history of bipolar disorder or non-affective psychosis. They can have no vision, hearing, or cognitive impairment, so it would interfere with participation. Obviously, this is a study of ECBT, or internet-based cognitive therapy, cognitive behavioral therapy, and the ability to access, navigate, and retrieve information from an electronic device is essential. They need to be literate in English. We're not offering this treatment option in other languages at this time. And they need to have access to a telephone, smartphone, or computer, or be willing to travel to access one. We know that cell phone coverage is not always complete across West Virginia, and not every participant will have high-speed internet in their home. We are able to provide a limited number of tablets for use in clinical sites. If that site is willing to have patients come back and complete their modules at that location. However, we're aware that that's dependent upon the availability of space and the administrative time to coordinate its use. Recruitment at partner sites across West Virginia will be asked to identify patients who match eligibility criteria in one of two ways. The first and most important is during clinical visits. During those visits, staff will be asked to review basic study information with eligible patients, those who meet the previously discussed eligibility criteria, during their clinical visit. The way that would work is if a patient is newly diagnosed with major depression, newly being no previous diagnosis or treatment in the past 6 months, they will be provided with an information brochure about the study. That information brochure would provide an overview of the study investigators, risks and benefits, some basic information on ECBT, what it is, and then information to contact our study team. They would also be informed that their information will be provided to us, and we will follow up with that patient to assess their willingness to participate and, if appropriate, enroll them in the study and consent them for participation. We would also ask for a daily review of case files. We are aware that practices can be busy and not every patient may be provided with information about the study. We would ask that the administrative staff of participating sites review the case files from each day to identify patients who might be eligible and who were not informed of our study during their clinic visit. The clinical staff would then be asked to provide the identified patients with contact information to the AMHI study staff for the purposes of reaching out to them to assess their interest. We will use that contact information provided by the clinic to reach out to each patient to further explain the study. They would initially be contacted by an invitation letter followed by a phone call. That letter would also provide information that would be in the brochure provided to patients on site. The phone call would follow up, make sure the patient had no additional questions, and consent them to the study if appropriate. At either method of recruitment, either in person or by phone and through a letter, in either case, the patient's informed consent would be obtained prior to study enrollment. At that time, the patient would be randomized to one of the 3 treatment arms. In exchange for their participation, the patients will be asked, as part of their participation, the patients will be asked to complete 10 study assessments and allow access to their electronic medical record data. This information will be linked to their survey responses as part of the study protocol. They would also be randomized to one of the 3 treatment arms that will be described in detail in a little bit. All patients will receive up to $290 for completing all 10 study assessments included in the project. There is one baseline survey that will take about 45 to 60 minutes to complete, and one baseline web challenge. It's an online activity meant to assess cognitive status. There are 7 tracking surveys and 1 final exit survey. In exchange for their participation, patients will be provided with $50 for each baseline assessment, including the survey and web challenge, $20 for each tracking survey, and $50 for the final exit survey. Participants will be expected to follow the recommended course of treatment from their primary care provider, regardless of the treatment arm they're randomized to. We are not asking participating clinicians to modify their treatment recommendations or strategy in any way. The ECBT provided to patients selected to one of the ECBT arms is considered adjunctive therapy and is not expected to change the primary care clinician's treatment recommendations. The 3 arms of the study are as follows. In the first treatment arm, it's treatment as usual. The the patient's primary care provider would assign whatever course of treatment in their judgment the best for that individual patient, and the patient would complete 10 assessments and allow access to their EMR data. In the second arm, it's also treatment as usual, also 10 assessments, but the patient would be provided with access to the electronic cognitive behavioral therapy, or access to ECBT. However, it would be unguided. They would be provided with minimal support and feedback, limited mostly to downloading the app, navigating the site, and some occasional contact reminding them to complete the recommended modules. In the third arm, it's also treatment as usual, 10 assessments, but it's more fully guided electronic cognitive behavioral therapy with comprehensive guidance and case management, routine contact, assistance with completing the modules or other tasks that might be challenging, and more comprehensive and regular review of symptomology. Brief overview of electronic cognitive behavioral therapy. ECBT is an internet-based form of cognitive behavioral therapy. The use of ECBT has become widespread only recently. There is great appeal to its use due to the scarcity of psychotherapists trained in face-to-face CBT in rural areas, and patient hesitation to pursue treatment due to expense, stigma, geographic availability, and inconvenience. ECBT is included among the recommended first-line treatments to mild to moderate major depression, and in conjunction with antidepressant medication for severe major depression. This brings up an important consideration for this study. We are not limiting participation based on severity of major depression, nor are we stratifying. Those of you who have been briefed about this study or involved in early discussions about this study may recall design where we stratified by depressive symptomology. The initial research design was to stratify based on mild, moderate, or severe major depression. However, we've since changed with PCORI's approval our research approach, and now we'll be including the severity of major depression as a covariate rather than a stratifying variable. The clinical commitment, or the commitment for participating sites, is as follows. Participating providers will be asked to recruit for up to 2 years, depending on the time they become involved in the study and the recruitment that is occurring at that site. We are aware that staffing changes happen, that there's an expectation that recruitment may proceed at a pace or with a degree of ease that is not realized once the study is underway. We will work with each site to review recruitment and adjust as necessary. Either way, patient recruitment will occur for 24 months, begin in March 2020, and those sites who come on board at whatever stage would have the opportunity to join us for the remainder of that 24 months at whatever point they enter. Clinics with participating providers will be asked to abstract EMRs for all consenting patients for up to 5 years after enrollment. We are asking the patients to consent for regular review of their records for up to 5 years after the start of the study. We are obviously interested in longer-term outcomes and would use this information to assess longer-term patient outcomes. For participating in the study, each clinic will receive up to $2,000 per participating provider per recruitment year. This says up to, that's assuming that each clinic or the clinicians at that site are participating in the full 12-month period for that year. But after consultation with the PBRN and some of our clinical partners, we feel this is the fairest way to provide compensation for what we understand will be an administrative burden and time commitment on the part of both the clinicians in those sites and the facilities. So what will we need from you? The primary ask is patient recruitment and referral to help us identify patients who meet eligibility criteria, provide them with information about the study and the contact information to the AMHI team so that reach out to that patient can occur, and recruitment and consent can be completed when appropriate. We would also ask for regular abstraction from the electronic medical record for each patient once they have provided informed consent and have been enrolled into the study. That would occur at regular intervals throughout the study and less frequent intervals once the 12-month period of participation for each patient has lapsed. We realize that all of these activities are an additional burden on your staff, and we're trying to make that as minimal as possible. As previously mentioned, Michelle Tonkin has been added to the team to serve as a primary liaison. Michelle will work with each of you to assess your needs, be able to provide whatever support we can, including recruitment materials, information sheets, flyers for your waiting rooms. Provide means of communication back to the study team and a regular presence in your facilities to provide updates and feedback when necessary. We also will provide IT support for data abstraction and transfer. This includes the technical support for abstracting information from records and IT support for making sure that information is transferred and secured, stored, in a secure and HIPAA compliant way, as well as legal review and support to make sure that our data use agreements and transfer protocols are all compliant with the appropriate legislation and policies. We will also provide webinars. PCORI is obviously engaged and emphasizes patient involvement in decision making. We will provide a brief tutorial and information session on shared decision making to our patient participants. That information will be available on the website as well as being done in person at the time of recruitment and consent. We will provide webinars, both those facilitated and directed by the research team and those identified as being of potential interest on treatment of major depression, mental health disorders, and shared decision making, with the hope of being able to provide CMEs for participating clinics and clinical staff. We hope that this is not only useful information, but an added benefit to those clinicians who choose to participate with us on this study. We know that there would be a number of barriers and lessons learned as we move forward, and we plan to host a forum for sharing that information, providing feedback to the research team, a way for us to provide regular updates to participating sites and clinicians. And we will have optional moderated forums for participating providers and clinic administrators. We see this as an opportunity for us to provide feedback to you, as well as an opportunity for you to share with us and with others information on what's working or not working with patient recruitment, data transfer processes, any barriers that are coming up with patient communication or participation, and any other support that we can provide to facilitate successful completion of this study. The steps of the study for the participants look like this. In step one, the clinic provides contact information for eligible stations to AMHI study staff after providing that patient with an education brochure and information on the study and obtaining their consent to provide us with that information. Our team here would then contact the patient to confirm eligibility, consent them, and enroll them into the study. At that time, the patient would be randomized to one of 3 treatment arms, and then spend the next 12 months providing information in both the baseline and follow-up surveys. The clinics who are the treatment home for those patients would be asked to provide access to EMR data and regular abstracts of those data to the AMHI study team during their participation and for up to 5 years after patient enrollment, although on a less frequent basis. Thank you for taking the time to watch this video. If you have any questions or any additional information is needed, feel free to contact me at either the phone number listed below or through email. My address is there, and I look forward to hearing back from you. Thank you.